Welcome to Med1 Pager. My name is Benjamin, and I'm going to be talking about acute ischemic stroke. And this was recently known as the vascular accident, or known as stroke syndrome. So in this video, I'm going to cover the pathophysiology of the disease. I'm going to talk about the risk factors. I'm going to cover the anatomy of stroke, talking about the different high-yield facts about the different arteries of the circle of Willis. I'm going to cover the investigations that we can do in stroke. I'm going to talk something about the things that mimic stroke and how to rule them out. And then I'll move to the management of the disease. So when it comes to stroke, acute ischemic stroke is characterized by the sudden loss of blood circulation to an area of the brain, typically in a specific vascular territory, and this is going to result in corresponding loss of neurological function. So what happens is that we have any cause, which can be a thrombotic cause or an embolic cause. Thrombosis, whereby we have a clot forming at that specific point and staying there, occluding that vessel. Or we can have an emboli, which is a clot that breaks off somewhere else, dislodging into another vessel within the cerebral circulation, leading to the stroke. So when this happens, we are going to have decrease in the amount of blood that area is receiving. And if it goes below 10 mils per 100 grams of brain per minute, we are going to have, that is going to be the core, or we call the core of the ischemia. And then we shall have an area around it. And this is an area which has reduced blood flow, yes, but it is salvageable. It is receiving some collateral circulation from the surrounding vessels. And this is called the penumbra. And it is going to have a blood flow of less than 25, but more than 10 mils per 100 grams of brain tissue. And this one is salvageable within hours. So what happens after ischemia has taken place is that we have depletion of ATP. And when ATP is done, the pumps, these pumps that use ATP to pump sodium, calcium, potassium are going to fail. Then we shall have sodium and calcium influx into these cells. And when sodium and calcium influx, the water is going to follow the sodium. We shall have edema occurring, what we call the cytotoxic edema. And when this occurs, there's release of glutamate from these neurotransmitters, and glutamate is excitatory. So when glutamate is released, NMDA receptors are activated and we have excitotoxicity. And when excitotoxicity happens, calcium is going to enter. When calcium enters, there is going to be an overload of it, and we shall have free radicals being produced. And these free radicals are going to cause massive cell damage, as well as other enzymes that are going to also come in and cause the breakdown of these cells. Then around 4 to 6 hours later, we're going to have a breakdown of the blood-brain barrier, and we have vasogenic edema occurring. And this one's going to peak within 3 to 5 days. And after this period, or within this period, we're going to have inflammation where cytokines are produced. We have microcirculatory failure, and the penumbra will also be consumed. Then later on, we shall have liquefactive necrosis of this tissue that has been destroyed, and the macrophages will clean that up. We shall have encephalomalacia as well as cystic activity. So sometimes we have a hemorrhagic transformation of a stroke, and this occurs in about 5%, and it may be spontaneous or it can occur when we give the thrombolytics. So what happens is that it occurs within 2 to 14 days after the stroke, and the mechanism of action is that we have reperfusion as well as the failure of the blood-brain barrier, and this is going to cause leakage of the red blood cells, forming vertice, or it can be a hematoma. And the effects of this are going to depend on the size of the hematoma. If it is small, we may be silent. If it is big, we may have the mass effect coming from this hematoma. So when we go to the risk factors for stroke, we have the non-modifiable and the modifiable. The non-modifiable will include things like age, sex, the race, ethnicity, family history, migraines with aura, fibromyalgia dysplasia, and other genetic disorders like the CADASIL, which is a defect in the Notch-Cure pathway, amyloid angiopathy, and angiopathy, as well as monocystinuria. Then the modifiable ones, we have hypertension, and this is the very most common, the very most important modifiable factor, hypertension. We have diabetes, we have hypercholesteremia, we have obesity. When it comes to the cardiac system, we can have things like atrial fibrillation, whereby we have stasis of blood in the atria, which form emboli that can be seeded to the brain. Then we have the valvular heart disease, heart failure, and the PF cause. Then we have prior TIA. If someone has had a TIA before, or someone has carotid stenosis, we have things like lifestyle, which includes smoking, alcohol, inactivity, and drugs. Then hormones like oral contraceptives, postmenopausal hormone replacement therapy, as well as hematological disorders like sickle cell and hyperhomocystinemia. All these are going to be causing or increasing the risk of developing stroke. So when we go to approaching a patient with stroke, we need to do history, and the purpose of the history was going to be to identify risk factors for atherosclerotic and cardiac disease, as well as identify the potential stroke mimics and causes in younger patients, because most of the time someone is young and they get stroke, probably there's something else going on underneath there. We want to establish also the time of onset of this stroke. And this is important because if we can establish this time and they are within the window of thrombolysis, and that is within 4.5 hours after onset of symptoms, we can do thrombolysis, thrombolytics. Then we have the clinical presentation of these patients, and these patients are mostly going to present with acute neurological deficits. And those can be in the motor, the sensory, the visual, the speech, the cranial nerves, the cerebellar, and the level of consciousness. So in the motor, we can have hemiparesis, monoparesis, quadriparesis. We can have hemisensory deficit. We can have monocular or biocular visual loss. We can have visual field defects. We can have diplopia. We can have speech disturbances like dysarthria, aphasia. We look at things like Wernicke's aphasia, Broca's aphasia, which are basically problems with either hearing or understanding what language or what is said, or problems expressing themselves, which is called expressive aphasia or Broca's aphasia. Then we have things like loss of balance, that is ataxia and vertigo, and this will occur if we have a stroke in the posterior part, which has the cerebella. They may have a loss of consciousness. Mostly if there is interruption of the RAS, the reticular sending system, because this is the area of the brain that is important in maintaining wakefulness. So when we go to the stroke syndromes or the arteries, this is one of the most important concepts and what will most likely show up on your examinations most of the time. So what happens is that these not only help us understand what part of the brain is affected, but also when it comes to understanding the territories of these arteries, they can help us know that probably this is not a stroke, this is a mimic, because mimics will always not be specific. They won't have a vascular territory of research. They may be widespread focal deficits. They do not obey the laws of the vascular territories. So we know the arteries that supply the arteries that supply the brain are going to come from the carotid arteries or the vertebrobasilar arteries. So the carotid arteries are going to come and they give off the common carotid is going to give us the internal carotid, which is the brain. And when it reaches, the brain is going to give off the ophthalmic artery, as well as the upper arteries, the anterior choroidal artery. It's going to give off the anterior cerebral artery, the middle cerebral artery, and the vertebrobasilar system is also going to come from behind, and we shall have the basilar artery giving off the pontine artery, superior cerebral artery. And these are going to form an anastomosis. They are going to be joined by the communicating arteries. We have the posterior communicating and the anterior communicating arteries, and this is going to complete the circle of Willis. And this circle of Willis is important because it is going to always act as an anastomosis. So if we have a blockade in one of these vessels, through this communication, we are able to supply blood to any of those parts. So one of the branches of the internal carotid, which is the middle cerebral artery, is going to be the mostly affected artery when it comes to the vascular territory of the internal carotid. And for it, it's going to it's going to cause deficits in the contralateral face or arm more than the leg. Goodness. Then we shall have sensory disturbances. We can have aphasia if it's a dominant hemisphere. We can have neglect if it is the non-dominant hemisphere. Then we can have hemianopia. We can have gaze preferences also setting in. So what happens? So a mnemonic to remember this is that you just think of MCM, middle cerebral artery, and you say mouth, comprehension, attention. So the mouth, we can have aphasia, comprehension, where we have things like neglect, and then attention is also going to be affected when you look at the gaze preference and stuff like that. Then the anterior cerebral artery is also a branch from the internal carotid, and we're going to have the contralateral leg. The leg is going to be weaker than the arms. Unlike the weakness in the legs is going to be more than the weakness in the arms. Unlike in the middle cerebral, and then we shall have sensory and frontal signs coming in. And you know the frontal lobe controls the impulses. It controls, it is important in continence and also helps with the gait. So these people have commonly what is known as the wet, wobbly, and wacky, which means the wet they have incontinence, wobbly they have gait apraxia or they have gait disturbances, and wacky is that they have these psychiatric symptoms. They have disinhibition. So when you think about the anterior cerebral artery, just think about the legs as well as frontal lobe signs, and that is wet, wobbly, and wacky. Then the posterior cerebral artery, we have visual loss, because this is again the region where we have things like the occipital lobe, where we have the visual center. So visual loss is going to be very common. Then the vertebrobasilar arteries, if we have a problem there, this is actually what supplies the brain stem. So if we have issues there, we're going to have both features in the cranial nerves and the motor nerves, but the thing is, these are cost signs. So the cranial nerves are going to be affected on the ipsilateral side because we are going to affect the blood supply to the nuclei before they cross it or before they decassate. So on the same side, the cranial nerves are going to be affected. Whereas when you look at the motor signs on the opposite side, they are going to they will be affected on the opposite side, and that is the vertebrobasilar artery that supplies the brainstem. Then we have the lacuna arteries, and lacuna arteries are going the lacuna stroke syndrome. It's going to occur when we have infarction that is deeper on smaller vessels, smaller penetrating vessels that go deeper into the parenchyma of the brain, and these ones are going to most of the time be selective. Either you may have someone having pure motor symptoms or pure sensory symptoms or ataxic symptoms only, and they may not have cortical signs of the cortical signs anyway. So these ones are little, they are localized, and they are limited, and that is to do with the lacuna strokes. So we have some investigations that we can do. Investigations can include doing a bedside, which can be RBS. So what we're going to do is basically we want to rule out the stroke mimics, and then we want to do imaging to see whether it's a hemorrhagic or ischemic stroke, because the management of those two is going to be very different. Then we want to also rule out some risk factors. So we're going to do bedside. We can do the RBS, we can do vitals, ECG, we can do the SpO2. We want to do the neuroimaging if it's a non-contrast to rule out the bleeding. If it is, we can do MRI to rule in early ischemia, because most times a CT may not be able to actually tell ischemic changes very early on. And then we have the carotid Doppler, maybe to see if we have stenosis of the carotid vessels, and so on. Then we do the labs for CBC, urinary electrolytes, creatinine. We have LFTs, coagulation, and things like that. So these are generally we're going to try to get a baseline of the patient. Then we have the cardiac tests like ECG and echo, because most of these strokes, many strokes actually are going to come from cardioembolic. They're going to be cardioembolic in origin, and this is mostly going to occur when you have things like atrial fibrillation that is proembolic. Yeah, Then we have specialized tests like autoimmune tests. We may do thrombophilia screening, CSF, because if the blood is thick, it's also going to be easily thrombotic. So we have the stroke mimics, and these ones can be categorized into the structure and the function. So structural functions can be tumors, it can be subdural hematoma, can be an abscess, encephalitis, it can be multiple sclerosis, peripheral nerve or radiculopathies, and vestibular disorders. These all can mimic stroke. Then the functional ones include the seizure, where we have the thought paralysis, and this is in the post-ictal state after someone has seized. They may have cessation of all function, they lose motor control for some time, and that's thought paralysis. We may have the migraine aura, we may have hypoglycemia, we can have electrolytes imbalances, we can have toxins and drugs, then we can have syncope, and it can also be psychogenic. So when it comes to the management, you want to stabilize the patient, you want to do the EPCs, that is the airway, breathing, and circulations. You want to do the imaging and labs within less than 60 minutes. So that you can consider reperfusion therapy. And we have the IV recombinant tissue plasminogen activator, that is RTPA, which can be both intravenous or intraarterial. Then we can secure the airway, we can optimize the blood pressures, we can treat the fevers, because if we have high temperatures during the stroke, high temperatures increase the rate of death of neurons. So it's very important that a fever is always kept to a minimum in someone with a stroke. And in some studies, they have shown that hypothermia is somehow neuroprotective, but not yet approved in the management of stroke. Then we can have oxygen. We need to provide us enough oxygen for these cells that are experiencing the ischemia. We want to give fluids to prevent hypotension. We want to correct hypoglycemia. We want to correct hyperglycemia. Then we have fibrinolysis in acute ischemic stroke. So this is when we give something, maybe a recombinant TPA or the TPA. So the recombinants include the alteplase, and we avoid streptokinase nowadays because it was started to have some mortality. It has some non-good things. It has a lot of side effects. So the best time possible is within 4.5 hours, and the best is within less than 90 minutes to give the TPA. So we have the inclusion and the exclusion criteria. So inclusion, if it's an ischemic stroke, we want to continue and give TPA. If we have a measurable deficit, we can tell which artery is actually affected. If the CT excludes bleeding or a large infarct. Then exclusion, if you have had a recent bleed, we don't want to really give TPA because this could cause rebleeding. If you had trauma, if you had surgery, if there's prayer, intracranial hemorrhage, if you had a BP greater than 185/110, if you have an anticoagulated patient with an INR greater than 1.7, if the glucose is less than 50, and if we have a large middle cerebral artery infarct, we want to avoid giving TPA. And we have the risks. The risks of giving TPA, one is intracerebral hemorrhage, intracranial bleed, can also cause angioedema. Then the benefits is that it can give a good outcome because we may actually be able to save these cells from dying. Then we have some special things like antiplatelets is not a contraindication. It's not antiplatelets not contraindication to fibrinolysis. And when we give, so if we are using the direct or anticoagulants, we want to avoid those. And large infarcts most times have a poor outcome and they have a high risk when we do fibrinolysis. So if you have a large infarct, you don't want to do fibrinolysis. Then we have mechanical thrombectomy, which is another kind of people. These patients who cannot have IV fibrinolysis, and for it has an extended time period, which is up to 6 hours before, and now they recommend even up to 24 hours in select patients, and that is according to the American Heart Association of guidelines 2018. And the recommended is 6 to 16 hours. So within 16 to 16 hours, you have that where you can do the mechanical thrombectomy. So most times in stroke, when someone gets stroke, their BPs tend to go up. So hypertension is very common in these patients, and it is important. The trials have shown that there's no benefit in reducing this hypertension, and it may actually cause harm because the body is trying to increase the blood flow to the brain, which could actually be helping to save the ischemic penumbra. So if you drop the blood pressure very fast, the ischemic penumbra is going to, remember the ischemic penumbra is the one that is having a blood flow of less than 25 mils per 100 grams. So if you reduce the blood pressure, you may drop it even further, and it may also experience ischemia and worsen on the existing deficit. Then we have a goal. So we want to treat only hypertension. If we are having a systolic blood pressure greater than 220 and a diastolic greater than 120. And also, you may also want to reduce the blood pressure if you are considering giving TPA. So the goal is to reduce it by 15% in 24 hours. And then most of the times it's going to actually go down on its own. It's going to resolve spontaneously after some time. Then we want to lower the comorbidities. You want to lower if there are comorbidities like aortic dissection, if there's myocardial infarction, if there's heart failure, or if there's a hypertensive emergency. That is also a situation where you may need to reduce this blood pressure, maybe a bit fast. Then we have the role of anticoagulants. So most of these patients, we are going to give them anticoagulants for some extended period of time to prevent recurrence of this stroke. So what happens is that unless thrombolytics are given, we start with giving aspirin, that is a single dose of 300 milligrams, and then we continue giving 75 milligrams daily for now the long-term period. We are going to give the 300 milligrams for long-term. But if thrombolytics are going to be given or have been given, we want to hold the aspirin for at least 24 hours, then we shall begin again to give the daily dose of anticoagulant. And then in patients with atrial fibrillation, we consider giving them the antiarrhythmic drugs, but also warfarin is preferred. Most of these patients, most of the trials or the studies that are done have shown that warfarin is better for patients with atrial fibrillation. So we have come to the end of this video, and we have covered a lot about acute ischemic stroke, and there's still a lot, but I've tried to cover most of the high yield points when it comes to stroke. So thank you very much. My name is Benjamin. And if you have enjoyed this video, if you have learned something, if you have understood stroke, I would be glad if you left a comment, if you left a like, or share this video with a friend. Thank you very much.